Good evening, Dr. Namrata.
Hi, Alice, how are you?
Hi.
So I think we would like to welcome everybody here. And today again, we are having a unique program which has been coordinated wonderfully by Dr. Paras Mehta. And Shroff Charity Eye Hospital is our co-host today with this program. And thank you, Dr. Umang Mathur. Thank you, Dr. Ritu Arora ma'am, for being there, and all the other faculty from Shroff Eye Hospital. Paras, please, we can take it forward. I think the topic is very interesting. X-files and keratoconus, all those things, perhaps even we don't know answers of, and I'm sure it's going to be a great learning from one another.
Good evening, everyone. Thank you for being here for this wonderful session to be hosted today. This is the third meeting of the year. And today, Shabina, can we have the first slide, please? And today we have both the Shroff Center from Delhi who would be participating with their cases for this particular meeting. The topic of today's meeting is Ectasia X-Files, Unravelling Mysteries in Keratoconus Management. As you all know that this particular event is very specifically looking after the corneal cases. And we can have and you can, shoot your questions into a Q&A box. It is almost like as if you are, in the ward and listening to the grand rounds. Today, for our this meeting, we have esteemed panelist, Dr. Umang Mathur, who is the CEO at Dr. Shroff's Charity Eye Hospital, New Delhi. Dr. Ritu Arora ma'am, who is a head cornea services at Shroff's Eye Center, New Delhi. And everybody knows Dr. Ritu Arora ma'am, as she was earlier working at Guru Nanak Eye Hospital. Dr. Rishad Shroff, a medical director at Shroff's Eye Center, a brilliant young chap who would be contributing to these discussions. We have our own people from CSI, Dr. Rajesh Fogla, a senior consultant and director cornea at Cornea Clinic and Cataract Services at Apollo Eye Hospital, Hyderabad. Everybody knows Dr. Fogla. He's a founder person for Cornea Society of India. Dr. Praveen Krishna, who is the director of the Cornea Institute at LVPI. Dr. Praveen is involved in a lot of research in keratoconus. Dr. Vikas Mittal, a medical director at LGI Institute. And Vikas has a lot of contributions in this field. I welcome all of you as panelists here and our own CSI executive members who would be contributing to this. With this, I would like to introduce my co-moderator, Dr. Neha Kapoor. She's senior consultant and consultant at Dr. Shroff's Charity Eye Hospital, New Delhi. She has done a lot of background work for this meeting, and I would request Neha to give a brief introduction about this session and start with the case series.
Sure. Thank you very much.
Neha, it's all yours.
Yeah, so thank you very much. We'll start the session today. So we'll be focusing on 4 topics today. And so we'll be talking about cataract with keratoconus, where this is an important one, hitting the bullseye, and we'll have Dr. Apurva Agarwal talk about it. We'll talk about exaggerated response post-CXL, eye drops post-40 to see how common that is, and the refractive conundrum in keratoconus. So as the incidence and diagnosis of keratoconus is increasing, we are likely to see more and more cases of cataracts in keratoconic eyes going forward. There are multiple factors to account for while tackling cases of cataract in keratoconic eyes, including IOL calculation, what kind of wounds do we like to construct, what is the type of IOL to be implanted, and the visual rehab modality post-op. So IOL calculation, like we all know, has multiple challenges in keratoconic eyes. Firstly, the IOL calculation assumes the ratio of anterior to posterior corneal power, which is not preserved in keratoconic eyes. Also, mostly these eyes have longer axial lengths and deeper anterior chambers, because of which the effective lens position is different when compared with a normal eye. And thirdly, these keratoconic eyes, the corneal curvature is often variable in a specific meridian, making the corneal keratometric power meridian measurements non-orthogonal. With this background, I'd like to invite Dr. Apurva Agarwal, a cornea fellow at Shroff Eye Center, to please present her cases. Dr. Apurva.
Good afternoon, everyone. I'm going to present an interesting case of IOL calculation in keratoconus patient. So this is a 48-year-old lady who came with a complaint of blurred vision in left eye, which has worsened in last 3 months. She was a known case of keratoconus with a no history of contact lens use. Vision in right eye was 6/6 and left eye was 6/24. With keratometry reading with AR was in the right eye 42.12 and 45.5, and left eye was 43.12 and 49.5. On slit lamp examination, posterior subcapsular cataract was noted in the left eye. On the pentacam, we saw the K1 value as 43.4 and K2 49.2. Patient wanted a toric IOL, so we counseled her about the residual cylinder would remain. On moving further, we did the IOL master 700 for the patient, and the 2 IOL master shows the reading of K1 as 42.8 and 43.3, and K2 50 and 51. Also, the IOL calculation shows +15 and +14 with the SRKT and the Barrett values. Furthermore, looking into the holiday EKR detailed report of the patient, it shows fairly consistent reading at around 4.5 millimeter zone. Looking into a cross of toric IOL, auto-K, IOL master and pentacam axis was matching, and also patient was not a contact lens user. Along with that, magnitude matched reasonably well between the auto-K, manual K, and pentacam. If we look into the cons of the toric IOL master's 700 TK magnitude was higher. IOL calculation is always very tricky in these patients. Also, the Virgin's formulas predict the effective lens position for the normal eye. But as patient was very much insisting on the toric IOL, we decided to go with a monofocal toric Alcon T9 model. It has also been published in literature that SRKT and Barrett formula shows the least hyperopic prediction error. So we proceeded with the SRKT power of 15 diopters. As this patient was having a moderate grade of keratoconus, we thought the biometric prediction error was assumed to be about -0.3 diopters. When we did the Barrett toric calculation using auto-K values, it shows the residual cylinder for around 1.59 diopter, or almost same residual cylinder with pentacam same K values, but with IOL master K values, it shows the residual of around 3.12 diopter. When we use the pentacam EKR values, it shows the minimum residual at 4 millimeter zone of around 0.19 diopter. And also the K formula shows the T9 power with 14, T9 model with 14 power. at 70 degrees. We finally went ahead with T915 Alcon model, and post-operatively, patient was doing reasonably well, as an unaided visual acuity was 6/9, and with minus 1.2 cylinder, it was around 6.6. Rest of all was absolutely normal, and patient was happy with the outcome. This is another patient with advanced ectasia who was using a stereo contact lenses in both eyes with Kmax around 76.8 diopter in the left eye. Calculation using pentacam values, IL found to be very, very high, around minus 31, minus 51, and minus 31.5. And because due to the severe K-conus, we use the standard case as 43.25. And IL power turned out to be plus 13 diopter in the left eye. In right eye, Kmax was 62 diopters, and IL master calculation shows the lens power of minus 2. Kane formula using the IL master values with the target refraction 0 shows plus 0.5, the target refraction minus 2 shows 4, and in the we're using the pentacam reading and keeping the minus 2 target refraction, it shows 6.5 diopter. And then we went ahead with non-toric IOL of plus 4 diopter in the right, plus 13 diopter in the left eye. Post-operatively, at 1 month, IOL was stable and no rotation was noted. The best corrected visual acuity in right eye was 6/6 with minus 1.5 diopter cylinder, and in the left eye, it was 6/15 parts with minus 5 spherical and minus 2 cylinder. Patient was happy with the outcome using scleral lenses in the left eye. I would like to conclude by saying that before performing any cataract surgery and deciding about IOL, we have to confirm the cylinder axis and magnitude on at least 2 devices. It is better to target the myopic refraction. Pentacam EKR map is a useful tool while planning the premium IOLs. Direct TK, TrueK, Kane formula, and SRKT gives very good results. And we should always confirm comfort with the contact lenses. Thank you.
Thank you very much, Dr. Apurva. So I'd like to open the house for discussion. If I may invite Dr. Umang, Dr. Praveen, and Dr. Rushad to please share their experience on similar cases. And then we'll proceed with some directed questions related to the case. So we thought before we go on to the IOL power calculations, it's also important to know, would you all recommend a contact lens holiday prior to doing a biometry for these eyes where most of these patients are contact lens users?
Yeah, so should I take that question, Dr. Nia?
Sure.
Yeah, so normally you would advise a contact lens holiday, but also the practical issue is that some of these patients don't see very well without their contact lens. So they have a issue going on a contact lens holiday. Generally for scleral lenses, since they don't really touch the cornea very much, probably 4 or 5 days is good enough. For rigid lenses, it would be a month, but you could ask the patient to continue the lens in the eye which he's not getting operated in and do the contact lens holiday in the other eye if he can practically manage that. So that would be what normally we look at as far as the contact lens period without wearing them before the cataract surgery.
Correct. The other and probably the most relevant question, what methodology of keratometry would you all follow in these eyes? And Dr. Umang, would you like to take that?
I wouldn't like to take that because, quite frankly, you need to, you really don't have a correct answer. But I think you need to use multiple devices. You can't just rely on one. The other problem would be, do you want to take the central area, or do you want to, the cone is very often eccentric, and that causes a problem. The effective keratometry generally would be the best, I would say. And so pentacam values probably would be the safest to take. The mild keratoconus, I think most would be okay. I mean, you could take the IOL master. The optical biometers probably are better than the manual keratometry and autorefractometer, which take a very small zone. The optical biometers today take multiple readings from various points, and that makes it a little bit better than the manual K. But I would go with the pentacam values as well as the IOL master values and take a call on that.
Can
On
we,
the IOL master, the TK
can
would
we,
also be a
can we
good
just
thing.
unshare the screen when discussion is going on? I mean,
Sure, sure, ma'am.
yes, yes. Yes, carry on, Prashad.
So, ma'am, I was just mentioning that the TK values now on the IOL master, it does measure posterior corneal astigmatism and the posterior corneal curvature as well. And we've also been looking at a few OCTs to see this, the anterior segment OCTs, although haven't really yet got around to a point of kind of presenting that data, but we are looking at that as another way of actually measuring the posterior cornea and then looking at the total keratometry values, because that's an important factor in keratoconic eyes. So along with these things, that would be important as well.
Dr. Praveen, would you like to share some views on that?
A couple of points, I think. Very interesting case that is presented, and also the previous question about the contact lens holiday. Like Rushad said correctly, sterile lens really doesn't touch the cornea. So even 24 hours of discontinuation of sterile lens should actually be enough, because you don't want the cornea to be swollen when you do the pachymetry or the epithelium to be irregular. But about RGP lenses, common knowledge was, at least understanding for refractive surgery, was about 3 weeks to 1 month earlier. But then again, like Prashad said, it's very difficult for a contact lens wearer who has keratoconus to discontinue lenses for such a long duration. So when we were trying to assess what is the effect of the contact lens wear on a patient's keratometry with keratoconus, to assess progression, we found that in about a week or so, the cornea actually comes back to its normal keratometry. So even with RGP lenses, 1 week holiday seems to be adequate. In fact, we published this in IGO 2 years back, but I can share the link of the article here if you would like. So 1 week seems to be enough for a contact lens holiday as well. Secondly, about topography, again, all keratoconus patients are not alike. And if you have somebody with a central cone, those are much easier than somebody who has an asymmetric and eccentric cone. And the pentacam seems to be the best device at this point of time, or a topography machine, for you to get an average central keratometry. And in fact, if you share your screen, here's a little tip for the EKR power calculation. The same, yeah. If you look at the lower, no, the previous slide, where you have the pentacam.
Yeah, sorry.
So when you calculate the EKR value, there are the things that you need to pay attention to is, if you look at the middle panel, there is a circular button right around there. Let me see if I can't mark it there. Yeah, right there. So if you click on that, you can change the diameter as well as the location from which you will get the calculation for the EKR value. And this is important in patients who have variable, slightly larger pupils. You might want to take a larger zone to calculate your effective keratometry, whereas in people with smaller pupils, you might want to take a smaller area. And you might want to center it exactly on the pupil, because if you have an eccentric cone, tendency is that you would like to center this more on the cone than on the pupil. But at the end of the day, the IOL is centered on the pupil and the patient is going to be seeing through the pupil. So just make sure that even after you resize this, it's centered on the pupil. Formulae wise, at least earlier teachings seem to show that theoretical formulas like the SRK2 performed the best in keratoconus. But I think recent literature has shown that Barrett, and your case has shown very elegantly as well, that Barrett seems to be a good formula for calculating IOL powers in keratoconus. Having said that, the last point is you also have custom toric lenses available right now. Again, no financial interest, but then I think the multinational companies have a limitation on the amount of astigmatism you can correct in keratoconus. Custom toric lenses, you actually can go very, very high, even 20, 21, 22 diopters as well. And these seem to have worked quite well as well. The hydrophobic custom lenses, and positioning is horizontal in almost all cases, but they correct very high astigmatism in keratoconus too. But great case.
What about Kane's formula? Because generally now everybody everybody propagates Kane's formula for keratoconus. Any thoughts on it? Although we are still, stuck on Barrett.
No experience with Kane formula. I have no idea. So.
We have used it, and I think Dr. Purva presented it in this case as well. The Kane KCN, it's the keratoconus mode of the Kane formula that you have to kind of select. It does reasonably well. I think there is an article that I read recently how Kane and Barrett Universal with the predicted posterior corneal astigmatism do better in severe keratoconus patients. So say you're above, and in that particular paper, they looked at keratometry is above 50 as severe keratoconus. And in values less than that, they looked at the EVO formula, which I don't have any kind of experience with, but they mentioned that is probably a better one for less severe keratoconus, although they said that the various different formulas do as well. But again, in this case, it was severe keratoconus, and the Kane formula did reasonably well in that second patient with a more advanced cone.
Right.
I think the
So
bottom line is that we have to have the total K or the true K. So anything which is measuring the posterior corneal curvature, so we have to use that kind of device, whether it comes through the swept source IOL master, or it comes through the, your Ectasia system, anterior segment OCT, which also gives the posterior curvature. Because using that with Barrett U2, and as per the AJO April 23 article, that has given the most reliable IOL power calculation. So that's what I would go with.
Ma'am, you said about Ectasia.
Yeah.
Using Ectasia for.
If in the Ectasia Tomy machine anterior segment OCT, you have a device for the IOL power calculation, which actually is measuring the keratometry from anterior and the posterior. And since it is a swept source OCT, so this is actually giving you better information about the posterior curvature vis-a-vis IOL Master 700, because the points which are mapped on IOL Master are lesser than the Ectasia anterior segment OCT.
So Ectasia, as far as we are concerned, is with the glaucoma people. And we hardly use Ectasia, especially
No,
for
it has. I have been using it. I mean, few
IOL
cases
partner.
which are post RK, those irregular corneas. It does have a software for IOL power calculation where it is just taking the keratometry. Biometry you have to put on your own. So rather few cases, IOL Master did not give us the keratometry, but Ectasia gave the keratometry.
And how does this keratometry compare with the EKR of Pentachem?
So, I mean, they were pretty close. But, because when you're doing those really bad RKs, sometimes even the EKR doesn't come out very well. It's happened. And I'm very happy with using that Ectasia system. So maybe you could use them.
And any take on the type of IOLs that we would like to use? Because the lower case, even toric, sometimes we are using. But for the higher case, is there any take on any use of EDOF lenses or multifocals? Of course, usually not. But what's everybody's opinion on that? Because these keratoconic corneas are also negative spherical aberration corneas. So does that change how we do things?
I think they're highly aberrated. I don't know. Technically, the Envista or the Bausch & Lomb lens is positive spherical aberration, and the rest of them are negative. So technically, that would make a difference, but I don't know practically. Praveen sir, what would you say to that?
Steer clear of all special lenses, EDOF or multifocal. And I think with the kind of aberrations that you have on the cornea, whatever lenses you have available in the market, I think they'll fall short of correcting anything.
Same result you're going to get.
Yeah. The other important thing that you mentioned, and I think you showed in the second eye of the patient, is very important to know the contact lens compatibility of the patient, because the last thing you want is if a patient is wearing contact lenses or going to wear contact lens in the future, and you put a toric lens in that eye, The contact lens will correct the corneal toricity, and patients will have to wear the cylinder in his glasses over the contact lens. So that is something that is very important to estimate before surgery as well.
Yeah, I would second that. I think it's very important. A lot of times patients will push you that I don't like my contact lens, and if you can remove that cylinder or something inside. But if somebody is used to wearing contact lenses prior to surgery, don't put a toric lens in, because they're never going to be happy with the quality of vision that you're going to give, and they'll be comparing it with the contact lens vision. And now if they want to wear, they'll need to wear a cylindrical spectacle number to correct the toricity that you've put inside in the IOL. So it's extremely important to get that history of contact lens usage. And generally, if somebody is a contact lens user, avoid a toric IOL.
I think it's important to look at the patient's history and see what kind of spectacle corrected visual acuity they had before the development of cataract. Because just like for ICL, when you implant in keratoconus, we look for best spectacle corrected visual acuity of 612 or 6.9 or better. The same rule will apply to a cataract surgery as well. In the presence of irregular astigmatism, no matter what method you use to measure the keratometry or what is the choice of the lens power, I think it will be still a bit difficult to hit the bullseye target. And as we were discussing on, if a patient is tolerant to contact lens, especially in advanced keratoconus, then at least in my practice, I choose 43 as standard keratometry value, and then put in a monofocal lens, taking into account that if this patient opts to undergo a corneal surgery in future, then we don't have to worry about, because anyway he's going to wear a contact lens post cataract surgery. So we can very well incorporate that power. So then you can go ahead, implant a monofocal lens, taking into account what your post corneal surgery keratometry would be. So I use that as 43. So it's important to sit with the patient and discuss and explain to them all the options, especially in terms of the lack of predictability. They may have refractive errors because we don't know what will be the effective lens position, whatever formula we use. For mild to moderate keratoconus, we are still okay. We may be able to achieve quite close to what we want. But I think for moderate to advanced, you have to be very careful.
Right. And that's actually what the literature agrees with as well, very correctly. So for moderate to severe keratoconus, every literature says that we should be using the standard K. And how about the wound creation for these patients? Would you prefer to do a scleral incision or a clear corneal incision?
So as far as whatever cases I've done, I've generally kept a limbal incision. I haven't honestly done a scleral incision specifically for keratoconus. I do that more for RKs, but slightly on the limbal side, posterior limbal would be what I do normally.
Dr. Praveen?
Probably doesn't matter very much. I think either of them should be quite all right.
Right. Okay, thank you very much. That was very insightful. So we'll move on with our next case now.
I think one more thing, doing phacoemulsification in these keratoconic corneas is again a different
It's a challenge.
It's a different ball game because the AC is so deep and you get distortions.
Right.
So, yeah. So
Aberrations.
so there are a lot of aberrations and distortions. And I think the best way people even have described using a contact lens on the surface so that, the distortion of the surgeons, they go away. So that itself is a big challenge. That's a different thing completely.
Right.
Yeah, patient's own contact lens, but definitely not a sterile contact lens.
Right. I'll now request Dr. Dupender Chauhan, who's a senior consultant cornea and refractive surgery at Shroff Eye Center, to present his case.
Good evening, everyone. I would like to thank Cornea Society of India for providing this platform to talk about the two cases. These are interesting cases. So I'll be talking about a significant amount of corneal flattening which showed up in these eyes. A keratometric regression is a rather desirable outcome of corneal cross-linking. Studies have shown that by the end of 2 years, up to 2 diopters of flattening is seen in many patients. This study by Rizk et al. Have also mentioned 3 or 4 eyes which had actually had a flattening of 4.8 diopters by the end of 3 years. However, they have not described these cases in great detail. So with this background, let's discuss our reports. So patient 1 had both eyes operated for cross-linking. He had a sequential cross-linking done at interval of around 3 months. Patient had a bilateral progressive keratoconus. Preoperative criteria, as you see here, preoperatively, the Kmax was around 56.6 diopters and pachymetry was around 432 microns. He had an uneventful cross-linking as addressed in protocol. And by the end of 10 years, if you see, there is an overall corneal flattening of 12 diopters and corneal thinning was also noted. Follow-ups have shown that the patient had actually lost up to 105 microns of corneal thickness for these past 10 years. So to summarize, in this patient, there is a progressive flattening noted in the steep case in the blue graph as we see here. The patient also had flattening of cornea, and along with that, there was significant thinning. At 10th year of follow-up, patient had his disciform area of corneal thinning with minimal scarring and deep posterior striations at the deeper stromal level. Other eye did not have very significant keratoconus. The Kmax was around 49.7. However, the outcome was very similar. In this eye, had a significant amount of loss of corneal pachymetry and corneal thickness had reduced by around 108. The flattening was not that dramatic, and the flat K had reduced by around 6 points. So, in this patient again, although there was a significant corneal thinning, there was no significant scarring, and there was an overall flattening along the Kmax, flat K, and the steep K axis. The other patient again was a 28-year-old male who had an uneventful cross-linking in both eyes. The first eye shows that there is a flattening of around 8 diopters at Kmax and by thinning of around 23 microns at the end of 13 years of follow-up. Now, the other eye patient had a more dramatic outcome in which there was a flattening of around 9 diopters and the thinning of cornea was noted by around 65 microns. Now, this patient again had a central haze on the cornea. There were some striations noted at the deep stromal levels. And unlike Vogue striations, these striations will not disappear on gentle pressure over the canvas. None of the patients had any significant corneal scarring. To summarize, we have 2 patients, 4 eyes, age group of more than 25 years, Kmax of more than 55 diopters in 3 out of 4 eyes. They all had a variable thinning after cross-linking ranging from 23 microns to 110 microns. Thinning, scarring, and deep posterior striations were noted in 2 patients, although scarring was not significant. Significant regression, however, was noted in all eyes, ranging from 6.5 diopters to 12.5 diopters. Chronologically, when you arrange the data in a graph form, we saw that after the initial stability of around 2 to 3 years, this was followed by a relentless phase of progression in all 4 eyes. Coming to the literature, now one of the study by Jimenez et al. Have shown that there was a significant amount of corneal thinning and regression noted by the end of 5 years in a patient who had undergone an uneventful cross-linking. The patient had a significant scarring and overall flattening of 11 diopters was noted, along with a thinning of around 203 cases reported by Luke and all have shown that all the 3 cases had a progressive flattening of 5 to 9 diopters over 12 years of follow-up. These eyes had no significant scarring at the end of follow-ups, and thinning was noted in 2 out of 3 eyes. So with this, I would conclude my presentation and open for any discussions. Thank you.
Thank you, Dr. Dipender. Can I request Dr. Ritu Arora, Dr. Fogla, and Dr. Paras to please opine on these cases?
I really don't understand what's happening in this case, though we've discussed it before. And my only thing is that and significant flattening has happened in my cases also, but then, I've observed them over 2 to 3 years of follow-up. And it was more on the hyperopic side, flattening to the tune of 3 to 4 diopters. But these two cases which Dr. Dipendra did discuss with me were very unusual. And I've seen those cases also. They are showing those vertical striae, and it's more in the form of scarring, and it is progressing. Why it is happening, I don't have any particular answer to that. Even when I reviewed the complications of CXL, and this progressive flattening has not been reported, but here maybe because Dr. Dipendra has a follow-up of more than 10 years, he's been able to come up with these two cases. Maybe others also had it. I can't say that.
Of late, we are seeing some cases with stromal thinning, and I ended up seeing one case with bilateral perforation, which was referred with TABCL. And that was, the CXL was done almost 3 years back. And then that patient ended up with corneal perforation 1, and after 2 weeks, the other eye also. So we are seeing such, stromal thinning cases. We have to look at what is the exact reason for that. There are some group of cases who would be probably showing an exaggerated response to CXL. I think Dr. Fogla also has seen similar cases.
Maybe some underlying autoimmune disorder, but then in this case, even that was not there.
Even the cases which I saw, it was like there was no reason for any autoimmune melt. Like the investigations turned out to be absolutely normal.
No, there are two publications, both in IGO. One is from Shankarai Hospital by J.K. Reddy, where they have reported 3 or 4 eyes with progressive flattening and stromal thinning all the way to DM. And that has that very typical appearance of a central discoid area of haze with flattening the folds. And then you have a stromal gutter kind of thing, which is with very sharp margins. And that's actually filled with epithelium, hypertrophied epithelium. And when the epithelium falls off, it looks like an ulcer. And there is another paper published last year again in IGO in the case reports. That's again from Eye Foundation, Coimbatore. And they have seen in a lady where this got exacerbated during pregnancy as well. And all these were at least 8 to 10 years post cross-linking. I have a series of about 8 or 10 eyes where cross-linking have been done at tertiary eye care centers. And 3 of them are doctors. And they presented with the same thing. They were okay for the first few years. Then they started having flattening. They became hyperopic. And this continued over a period of time to an extent that corneas, the average case in the range of about 29, 30 diopters with that kind of flattening. And they all, some of them have a central, very well-defined punched out stromal lesion, which looks like almost going to perforate. And when we did the DALC for these cases and sent the samples for histopad, the entire involved area, there is lack of keratocytes. And even after 8 to 10 years, if there are no keratocytes, I think that's something to be concerned with. All of them had, from the history, although they did not have any papers depicting what protocol of treatment was done, but based on from history how long the treatment took, it appears that they had the classical Dresden protocol procedure being performed. And if you look at the collagen turnover in cornea, it takes about 8 to 10 years. That's what the textbooks say, that in 8 to 10 years, the collagen turns over. So maybe in these eyes, because of the loss of keratocytes, there has been some change in the mechanism where the collagen turnover is affected. And that's why progressive loss of collagen is leading to thinning and flattening of the cornea. And then you're getting that kind of degenerative area and the stroma where you see the defect going all the way to the residues. We don't have an exact answer, but I think all these cases, if they are collated together, maybe we'll have some answer as to, but we have seen a similar lesion. Even I think Muralidhar told me Praveen is also looking at some of these in elderly ladies. We are seeing a central discoid shape of lesion, which appears very similar to in these kind of cases where you have that, hazy cornea with these folds and the cornea starts becoming very flat. And they have like a non-healing response also, like if you develop an epithelial defect or something, it becomes very difficult to heal. So there is some abnormality in the corneal collagen that makes it very difficult.
Sundar, I have one question for you. All these cases were done at Shroff?
Yeah, they were all done by me.
So, okay. So you know the protocol that you followed, because I
Yes,
have a series of 6 eyes, which I was discussing with Dr. Ritu Arora also, but all of these cases are referred. So we really don't know what the protocol was that was followed.
So
And
they were all done by me. They never
but-
developed any persistent epithelial defect. Even the
Mhm.
last year's OCT that we did, they didn't have any significant, or in fact, didn't have any epithelial hyperplasia at all in the zone which is involved here.
so epithelial
And
mapping was done for, or
yes,
would have been
yes,
done
it has
for
been
all.
done for one patient. We are waiting for the other patient to come for the review, and we'll do that and maybe then.
If you allow me, there is a slightly different thought process and take on these cases. We've just put together a series of 12 cases where when we put all the OCTs together and also the flattening that occurs on the cornea, and in addition, just like Dipinder showed, the typical folds with that central localized scar. They seem morphologically to be very similar to what you would see with CTK after refractive surgery. And refractive surgery, CTK, though typically has been reported after LASIK, CTK has been reported after PRK as well. So when we looked at the OCTs and tried to compare the CTK that occurs in LASIK with these patients, we found that the characteristic inverse pyramid kind of haze that occurs in CTK is present in these cases also of initial flattening and haze after surgery. And then when we did the confocal, again, though confocal shows in regular cross-linking as well, that you have a loss of keratocytes, even up to the area of the demarcation line, which never tend to return for a long time. These patients as well seem to show a complete lack of keratocytes in all the areas of the cornea after cross-linking as well. And with time, as you see in LASIK, CTK tends to recover spontaneously, and we don't know the trigger, it's apoptosis, but with time, the hyperopic shift tends to reduce, either because maybe patients are accommodating a little bit, but also the scar tends to disappear with time. And in keratoconus as well, maybe it's a little more severe because of the duration of exposure of the UV. But I think there is a phase where the CTK hyperopic flattening is reversed, which appears as if it is progressing again because it is returning back to the original curvature of the cornea. That seems to be the change that is occurring in post-cross-linking eyes in the early as well as the late phase. The thinning as well as the tissue resorption that I think Rajesh and all of you were mentioning, either it is a different pathology from what we just discussed right now, or it is a progression of this pathology long-term with failure to lay down a fresh collagen over time, leading to those facet-like appearance and thick hypertrophic epithelium over time. There is some histopathology, but we have not been able to find anything significant on histology that will point us to a specific diagnosis. These 12 cases right now, we're under revision in cornea right now, so hopefully we'll see it published there soon.
So what did you do for these cases, 12 cases, and what did Dipinder do for those cases which were having a regression and having, flattening or having hyperopia? How did you visually rehabilitate them?
I think we were very happy initially with glasses because they flatten quite a bit and patients are happy as well. But a lot of them have exuberant scarring that doesn't go away. It seems that the scarring patterns and cross-linking also they follow several different patterns. Typical scarring pattern, what you see in the periphery, that sort of like very fine fibrils that you have, center is often spared, seems to be desirable. Second type of scarring pattern is what Dipinder just described with the folds with extreme flattening. That seems to be transient and goes away. Third kind of scarring pattern is a more anterior diffuse scarring pattern, which seems to be permanent. That seems to reduce visual quality in patients as well. Typically also seen when you add on PRK with these patients. So those are the ones which are more problematic because vision doesn't improve over time. But the CTK-like scarring pattern, I think over time vision does improve and you need to keep changing their glasses and contact lens fit.
CTK following LASIK is more forgiving than CTK-like pattern following keratoconus.
No, but this is not CTK-like pattern. Though there is loss of collagen completely and it's scarring and it's not reversing.
It's
rather
not reversing.
progressing.
Even I agree with that. The patients that I have, it's not reversing.
It's
And
not reversing.
They are
It's just
very unhappy.
progressing.
Actually, they're very unhappy because they cannot be visually rehabilitated. I think I sent one example to Rajesh and to you also, Praveen. So I think we should refer appropriately because this is not, I mean, visual rehabilitation is a problem in these patients post-operative.
The paper by George Kimionis, which was referred to, referring the progressive corneal flattening at 5 years, if you look at the corneal OCT in his paper, you will see the same gutter-like defect in the stroma, what we have been seeing in these cases. So that kind of gutter-like stromal defect is filled with epithelial hyperplasia, but it was not recognized because it was just termed as progressive flattening. So nobody really looked at it. So I think it's a condition like when you just see an occasional case, you are not alarmed by it. But in a referral practice, if you start seeing, like I just saw a patient day before yesterday, and this patient is now 39. He underwent cross-linking at the age of 30. And this was done at a tertiary eye care center in India. And he was okay for the initial 3 years. And then he started having a little bit of flattening. He was happy, as Praveen said, because I was getting better. But in the last 2 years, he came with the vision of counting fingers close to face with K values of 29. And the same thing, he was referred as acute corneal ulcer with, decimetocele likely for perforation. But this was not an infective ulcer. This was just that stromal gutter where the epithelium had fallen off. And you could see that entire haze around the cornea.
So if I may ask a couple of things, like these 2 or 4 eyes, they didn't have very significant scarring. And usually when there's a failure of keratoconus, the thinning is associated with ectasia, but here we are seeing a significant flattening. So that is one, that picture is not very typical. Second, it's very typical that you see after 3 or 4 years of initial stability, then starts the regression period. So is there something that you'd like to add on to that? Why is it happening, or should it be more?
No, that's what I said. Given that hypothesis that the corneal collagen turnover happens to 8 to 10 years, this is based on some very old study. There is no recent study which can prove what is the turnover of collagen in the cornea, because when we were so we didn't have an explanation when we, like, why would these patients do well for the first 4-5 years, and after 6-7 years of cross-linking, suddenly you start seeing this progressive change, which is non-inflammatory. It doesn't induce any vascularization. There is nothing else. There is no AC reaction. So what is it that, so, a non-inflammatory means there is something happening. The stroma is dying, basically. So for me, that's the only logical explanation I have, is that the new collagen is not being laid down. So a possible therapy for this would be putting in these mesenchymal stem cells, like what people talk about, that you make a stromal pocket and introduce some mesenchymal stem cells, which will then try to repopulate the stroma with some keratocytes or some cells, which will then lead to regeneration of the collagen before you. So you, at that stage, when they start flattening, you have to think about doing some stem cell therapy, where you put in mesenchymal stem cells into the mid-stroma. I think this George Alio from Spain is doing that in keratoconus to try, because we know that in keratoconus, the keratocyte population is getting depleted. So they are now trying to do a therapy where they make the pocket and they introduce these mesenchymal stem cells.
But till then, we don't have any idea which set of patients would end up into this.
No, I don't think we can.
So unless we collate all the cases and look for common factors, things, we
Yes.
will not be able to come to a conclusion. These will all be like scattered reports and no uniformity. If you put everything together and if you all have all the protocols, what treatment they had, what riboflavin solution was used, then maybe you will have some answers or some guidelines which you can put together. Maybe the accelerated protocols which have evolved later may have a protective effect, because it may be sparing some amount of the corneal stroma in the deeper stroma. The earlier protocols where you use dextran, we know it thinned down the cornea by more than 100 microns. So it's possible that you have over-treated the cornea with the UV radiation.
Yes.
I think let's go to the third case, otherwise we'll keep on discussing this.
This is a very interesting case, it seems.
Okay. So the next case, Dr. Abhishek, if you could present your case, please.
Good evening, everyone. I'm Dr. Abhishek Agarwal, Fellow in Cornea and Anterior Segment at Dr. Shroff's Charity Eye Hospital, New Delhi. And today I'll be discussing a case on acute eye drops beyond 40. Presenting the case of Mr. X, 43-year-old male resident of Pilibhit, Uttar Pradesh, who presented to us with chief complaints of diminution of vision, whitish opacity associated with watering and pain in the left eye for the past 2 days. A known case of keratoconus in both eyes, he was a regular contact lens user for the past 5 years, and there was no history of any surgical procedure. A known hypertensive on treatment for the past 8 years. His current ocular treatment history included eye drop fluoromethalone 0.1% OD, eye drop moxifloxacin 0.5% BD, and eye drop ciprofloxacin 0.3% BD for the past 2 days in the left eye, which he had been prescribed by a local practitioner before he was referred to us. The right eye had a best corrected visual acuity of 6/18 parts with a scleral contact lens and an intraocular pressure of 8 mm mercury. On slit lamp examination, a central corneal scar with thinning was noted. On slit lamp optical section and parallelopiped illumination, an apical cone with prominent Vogt striae was seen. This is a slit lamp photograph of the right eye taken 1.5 years back when he had first presented to us. The left eye had a visual acuity of hand movement close to face with an intraocular pressure of 10 mm mercury and a central corneal scar was seen. This is a slit lamp photograph of the left eye when he had presented to us 1.5 years back. On optical section, corneal epithelial bullae, stromal edema, and an increased corneal thickness in the inferonasal quadrant were seen. Based on above findings, a clinical diagnosis of both eyes advanced keratoconus with left eye acute hydrops was made, and he was advised to undergo a pentacam and an anterior segment OCT for both eyes. The right eye pentacam revealed a significantly steep cornea with Kmax value being 76.7 diopter and the thinnest pachymetric values of 334 micron with an inferior steepening noted on the axial and sagittal curvature map. Compared to the pentacam done at the 1.5 years back, he had a significant decrease in the corneal pachymetric values. The left eye pentacam revealed a significant increase in the Kmax value being 103.3 diopter, and the corneal pachymetry through pupillary center was 1,236 micron. The ASOCT of the left eye revealed increase in corneal thickness, epithelial bullae, and a faint Descemet's membrane was seen. So based on the above findings, we made a surgical plan of left eye descemetopexy with C3F8 injection, and he was taken up the next day in the OR. On post-operative day 1, a half-chamber air bubble was seen in C2. The optical slit section showed a slight decrease in corneal edema. The ASOCT taken through the center revealed multiple cystic spaces in the stroma with some reduced corneal thickness. The following treatment was started: eye drop timolol maleate 0.5% BD for 1 week, eye drop prednisolone acetate 1% QID, and eye drop carboxymethyl cellulose 6 times a day. He's due for a follow-up in 2 weeks. So based on the above case discussion, I would like to pose the following questions to the panelists. What is the upper age limit of acute eye drops in your experience? And what is the preferred management technique and the role of compression sutures in the above scenario? Thank you. Good evening.
Yes, so the panelists, please, we'd like your suggestions again. So we've noted the lower limit of hydrops. I mean, hydrops have even been reported at 5 years of age, but it's slightly unusual because we normally have always learned that by 35, 40, the keratoconus stops progressing. But we've recently seen cases of 43, 47, and 52 that have presented with hydrops. So Dr. Namrata, would you like to opine?
I think we've seen cases in older age group also, and although it's not as common as the younger age group, but then it can happen and it is definitely there. And I think the case was well managed, except that I would now put compression sutures also, because that causes faster resolution as compared to the intracameral injection alone of a gas.
Also, now there are multiple compression sutures. Someone's talking about full thickness, someone's talking about partial thickness with or without descemetopexy. So are there any preferred techniques?
So I would use full thickness sutures because I think they work better than partial thickness sutures, which we used to use earlier. And I think Sunita has described this in Cornea Journal. And I think that is what we are doing, trying to also study whether sutures do make a difference or not, taking 2 groups where in another group, you're not putting sutures at all. But full thickness, I think, work better than partial thickness. Definitely.
And we were also wondering that how easy it is to pass sutures, because when they're describing full or partial thickness, the view sometimes in these hydrops cases is just so bad that you can almost not tell whether you're partial thickness unless you have an intraoperative ASOCT.
No, I know that Praveen is again going to say intraopacity, but then it does help a lot because you can actually see the edges of the, the torn Descemet's membrane, and then, pass your suture accordingly. So it is a useful tool. It does help.
I think
If you don't have it, even if you don't have it, you can still do it because that area will become a little darker. I mean, it'll appear to be a little darker as compared to the rest. But actually, you can see the broken edge and you can, pass your suture under visualization. And especially if you have RT view, then you can see everything magnified.
Dr. Sunita in her paper has specified that if you make an anterior chamber paracentesis and put in an air bubble, that air bubble will also help in delineating the edge. So that may be another preferred technique to pass the suture.
Yeah, that's what I do, because number of times your corneas are absolutely opaque and you really don't know where your needle is going because your Descemet's is like way too below. So I normally pass an air bubble into the anterior chamber so that it just, sometimes the air chamber even goes into the cleft. It goes through the opening into the cleft. So at least it delineates that, the broken area of the Descemet's, and then maybe it becomes a little easier to pass the suture, full thickness suture.
And then, ma'am, club it with the desmetopexy with a C3F8 or air?
I like to put C3F8. Otherwise, air gets absorbed very soon.
Yeah.
You have to keep going again and again.
I think
So
you can
I
do
would
a
like to share one
surgical-
complex. Sorry,
Yeah.
carry on, Dr. Paul.
You can do a surgical planning even with your anterior segment OCT in the OPD. So you take the patient to your OCT and you make a drawing, and you can, on the OCT, based on how it shows, because your sutures are usually placed 90 degrees to the vertical break that you have. So at least make a drawing so you know where exactly the break is, and that can help you as a guide in planning, placing your sutures. The other point of placing sutures is, remember that in the edematous cornea, if you take your bites there, they will cheese wire when you tighten them. So you have to try and take your bites in the cornea that is just outside the area of the edema so that you can get a better hold. At times, even mattress suture helps. If you feel that your sutures are not there, take a horizontal mattress suture on the normal cornea, pass it across, and then compress the suture. So what happens is the forward protrusion, it gets flattened. And then if you put an air or a gas bubble in the AC, it helps the two edges to get opposed together. Because the moment you flatten the cornea, the edges anyway approximate better rather than when they are stretched.
So, but sometimes we have like extreme edema going almost limbus to limbus. What do you do in those cases?
Those cases, sometimes we put a gas air bubble in the AC, and we also try to drain, like what Rasik Bajpai and Amrita have shown, that sometimes that if you have a massive corneal edema that's filled with fluid, you can do partial thickness like venting incision, and then you press on the cornea using a Marusel sponge. You will find that the fluid kind of seeps out from these pockets in the stroma, and then you are able to visualize a little better. Namrata can comment more on that because
No, quite right, Rajesh. Alternatively, you can do external massage also. You can actually
yes.
see the
This-
the lip of the Descemet's membrane, like Dr. Arora said, and you can actually, see on the OCT, and otherwise also that the thickness in front of your own eyes, the thickness of the cornea is actually reducing.
And at times, the first suture which you have passed needs to be revised by the end of the surgery. Because in front of you, as you said, that the edema keeps reducing. So the first suture, when I'm passing the last suture, I feel the first suture needs to be revised. So you may need to revise.
But in literature, all kinds of surgical suturing techniques have been described. Full thickness, going up to 90% depth, going up to 70% depth. And basically, the idea is that if you can compress the cornea, your decimetopexy works better rather than just decimetopexy alone. And I think Sunita doesn't even do a complete airfill. She does just a partial airfill, and those eyes have done very well. I don't know whether she uses gas, but
No,
from
sir.
the discussion, it appears that she just uses air and it works. Even the next day, the cornea looks much.
Yes.
Just air.
Even
She
the
uses just
paper
air.
from Japanese group, which mentions about partial, air fill, 0.1 cc air is injected into the anterior chamber, and it takes care.
Depends on the location of the break. If the break is inferior, then maybe a small air bubble may not work because the air bubble will not be able to tamponade unless you're maintaining a strict positioning of the patient. But a break that is predominantly in the center, in the upper half, maybe a 70% air bubble would still suffice. At least that. People have also described putting in like a DMEC graft or a DSEC graft to seal it from inside. And the last paper, when I was presenting this, Greg Maloney got up and said, oh, we have published on use of Rho kinase inhibitor to manage eye drops as well. So that's like because it helps faster migration of the endothelial cells. So that there is one case report by Greg Maloney.
Actually, presenting this kind of a case that eye drops does happen later. Now, for this thing, I was reviewing it. Peter Lipson group has presented even eye drops presenting at the age of 55 years. So it's like it's not
PMCD. We have seen patients with PMCD 55, 60 years.
PMCD, yes, but
with,
not keratoconus. PMCD usually presents.
But again, it's again the eye drops. At least that what we see in the clinical practice, because they are so infrequent that you're not able to put together. You know, again, it will be a wide variety. So there are theories in terms of eye rubbing, the severity of keratoconus, pre-existing breaks or pre-existing weakness in the Duas layer or the pre-Descemet's layer. So these are things that can lead to maybe future diagnostic equipments like with the corneal, which measure corneal biomechanics, we might be able to predict like which are the keratoconus cases, which may be more prone to, you know, developing a eye drop depending on reduced corneal biomechanics.
Because this gets me thinking that normally if a patient comes 34, 35-year-old keratoconus, you normally say, oh, no need for CXL because it's not going to progress. And whether one should be advising CXL for those patients, and then I don't know, the problem of flattening.
Management of eye drops is easier than managing these kind of degenerative stimulation.
20% of the cases still progress even after the age of 40 years. I mean, I think that is known.
Yes.
So
we are seeing a few patients, ma'am, like that also.
And reported a case of acute eye drops with perforation, and that was an old patient. I can't remember the exact age, but 50 plus with infection and perforation and acute eye drops. I have even seen, I don't know, I'm sure everybody's seen, but 2 cases of recurrent acute eye drops. I don't know. I mean,
I've not seen recurrent.
We have seen one, ma'am, very recently.
Recurrent eye drops.
Yes.
Because I've seen eye drops in a graft. I have seen eye drops in a graft which happens in the periphery at the host graft junction.
And eye drops even after cross-linking. I think that we all have seen that.
Yes. Okay.
We move on. Yeah.
So let's move on. This is the last presentation. Okay. Good evening, everyone. Today we will be talking about refractive management in 2 cases of keratoconus. So our first case was a 25-year-old male who presented to us in 22 for a refractive surgery opinion, and he had a history of collagen cross-linking in both eyes in 2017. At presentation, his visual acuity with a -14 diopter sphere and a -2 diopter cylinder in the right eye was 6.9, and his best corrected visual acuity in the left eye was 618 partial with a -14 diopter sphere and a -3 diopter cylinder. This is his pentacam in the right eye, where we can see a K1 of 50.4 diopters and a K2 of 52 diopters with a predominantly central cone, and the K max at 59 diopters in the thinnest pachymetry at 409 microns with a good mid-peripheral thickness. And this is his pentacam in the left eye, where we see a predominantly central cone with a K max at 67.9 diopter and the thinnest pachy at 385 microns. We planned an intacs for both his eyes in May 22 to regularize the astigmatism and reduce the refractive error. 2 months post the intacs, his visual acuity in the right eye was 6.9 partial with a -6 diopter sphere and a -8 diopter cylinder, and in the left eye was -8 diopter sphere with a -5 diopter cylinder, giving him a 6.9 partial visual acuity. This is his pentacam post the intacs in the right eye and the left eye. 2 months later, we did an ICL for him in both the eyes, and we had a happy patient with a visual acuity of 6.9 both eyes. Our second patient was a 27-year-old female who had history of using glasses since 14 years and had a disparity in the glass prescription since then. And she also presented to us for a refractive surgery opinion in 2021. At presentation, she had a refractive error of -5 diopter sphere in the right eye with a visual acuity of 6/6, and a left eye refractive error of -11 diopter sphere with a -6 diopter cylinder and the best corrected visual acuity of 6/18 partial. We did a contact lens trial for the patient in the left eye, and the patient improved well to 6/9 with a pros lens, but the patient was not keen on wearing a contact lens. The pentacam of the right eye showed us a K1 of 43.1 and a K2 of 43.7, and the steepest K of 44.4 diopters with the thinnest local at 526 micron, and the bad map was also normal. The left eye of the same patient showed us a pronounced central cone with the steepest K at 73.1 micron and the thinnest Paki at 460 microns. We planned an intax for the patient in the left eye with a CXL in March 21. 3 months post the intax and the CXL, this is what her pentacam looked like. And this is the clinical picture of the patient. Her steepest K was now at 69.5 diopters and the Paki was 446 microns. In the meantime, the right eye underwent a PRK in April 21 with a good visual acuity correction. 8 months post the intax, the patient underwent an ICL in the left eye and had a good visual outcome with a visual acuity of 6/6 partial. At the last follow-up recently in April 23, this is the right eye pentacam where we can see that there is a slightly decentered oblation. And this is the left eye, which is a stable keratoconus. The questions to the panel are, would there be any alternate management options in both these cases? What is your experience and indications of intacs today in keratoconus management? And would the laser refractive surgery be done with or without CXL in fellow eyes of keratoconus? Thank you. Okay, so these are cases. Oftentimes, of course, we know by default that in keratoconus also contact lens is ideally the best management. But a lot of times we get young seekers who are looking for non-glass bar, non-keratic contact lens options. So surgical modalities, what's your experience on intacs? Do you really want to do intacs? Because if we saw in the first case, post intacs, the cylindrical number actually went up from -3 to -8. How predictable are they and do they really help? Dr. Praveen, Dr. Fogla, would you like to comment, please?
I think intacs, again, it's about case selection. I think the greatest value for intacs has been in patients who have asymmetric keratoconus, where you try to center the cone. It is not as predictable as it is made out to be because it is not a very precise technique, but in the process of centering the cone, bringing the cone into the central visual axis will increase the sphere and potentially will change the cylinder as well. The goal of the intacs is not just to reduce the cylinder, but to regularize the cornea more. So an irregular cornea with a -3 cylinder and topography might be worse off than a regular cornea with a -8 cylinder. So from that perspective, I think it still works really well.
I think post-LASIK ectasia is another place where you can do an intacs because again, most of the time they're decentered cones in that, and that really helps along with cross-linking in that.
And what about the other eyes? Like this second patient we had a very normal looking pentacam. The bad map was perfectly normal. She was 27 years old with a frank cone in one eye and a normal spherical number in the other eye. Would it be okay to do a PRK or should it have been clubbed with a CXL?
I mean, you call me conservative, but I wouldn't do refractive surgery on the other eye of a patient who has keratoconus. It is a bilateral disease. And if you're doing cross-linking with PRK, like we discussed in the first case, cross-linking again might lead to potentially unstable refractive errors. And if you're worried about progression of keratoconus, then we shouldn't be doing PRK in the first place at all. So cross-linking with PRK, I mean, it's semantics. It's PRK followed by cross-linking because you want to correct the refractive error. Probably is not justified. But PRK, in addition to cross-linking, because you're trying to control the progression, but you also want to ablate some of the cornea, not trying to correct the complete refractive error, but trying to regularize the cornea, that I think is still justified.
Dr. Fogla, your take?
And I completely agree. And if you look at the presentation, if you look at the map in the right eye, it's not normal. If you look at it carefully, you will see that it's showing very early signs of keratoconus. And I think it's just a matter of time. What you were describing in the post-op map as a decentered ablation may not be a decentered ablation, but just the starting of ectasia, because ectasia, when it starts, it makes the ablation pattern look like a decentered ablation. The lower parts starts becoming steeper. So just keep that patient on a close progression. I burnt my fingers trying to do a combined PRK and cross-linking, especially after the encouraging reports from Keratoconus and some other people who showed very good results. And for the suspicious topography or patients with very good thickness and minimal, keratoconus, we tried combining the treatment. They do well in the initial period, but over a period of 1 to 2 years, as with flattening, sometimes you can make them hyperopic or they can end up with some unpredictable refract. So it's you can't control that. In the initial period, it will look like as if it's doing well. So a sequential approach is much better. If you want, you can maybe cross-link the patient first, and then wait for 6 months, 1 year. And when you have a stable topography, and if you really want to knock off the cylinder, you can go ahead and do a topo-guided PRK to knock it off. But till we understand more about cross-linking, I have stopped doing those kind of combined procedures, because I know that managing them later on when they come with a corneal complication, it becomes much more difficult. So till we have a better understanding, I think we should not rush in and try to do too much. In terms of, I was only confused about, you had 8 cylinders and then you put in an ICL. We know that ICL will not correct 8 cylinder. So there must have been some refractive error that was left behind, unless you are using one of those customized phakic IOLs, which some of the Indian manufacturers are giving.
No, it was, yeah, we're using the regular star. Initially, when we did that time we were using
But in terms of using the intracorneal rings, I just have experience of about doing 5 or 6 eyes using the corneal stromal segment instead of the intracorneal rings. I was a bit skeptical in the beginning, but after doing these 5 or 6 cases, I'm quite impressed and in fact amazed with the outcomes that it can give, because you can put it much more superficial. You don't need to put it at 400 or 420 microns depth. You can put them at depth of something like 170, 200 microns. You do it within a 5 to 6 millimeter zone, and it gives a much better outcome than what we have been seeing with the Intacs. And since it is biocompatible tissue, like you're putting in corneal allogenic tissue, the risk of extrusion in the long run would not be there. And it's a reversible procedure. So for me, doing anything in the patient's eye which is reversible makes sense, because you can always go back and revert it. If you don't have an undesirable outcome, you can remove that segment, or you put in a phakic IOL and patient is not happy, you can go back and remove it. But doing a procedure like topo-guided PRK and cross-linking, which you cannot undo, you don't even know whether you need to use mitomycin or don't need to use mitomycin. You're already killing keratocytes with cross-linking, and with PRK added insult. What you do to the cornea, we are not very clear. So what we don't understand, I don't think we should, if we are conservative, we maybe in future we understand it better, we'll be able to do it. Benefit to our patients.
And in the first case, would it have been okay to just do an ICL in the first place and not do Intacs at all?
No, if the visual acuity with the spectacle correction would have improved up to 6/9 or better, then you could have just done ICL without doing anything in the cornea. But like Praveen said, that if you have an asymmetric cone, you can put in a single segment, lift up the cone, improve, reduce the coma, the higher aberrations reduces, patient's quality of vision gets better, and then you go ahead and do an ICL. Because we see a lot of patients with keratoconus where ICL has been done and the patient visual acuity is only 624, 618, and they are very unhappy. And that's because they did not have excellent vision with spectacles, and that vision is not going to get better by putting in a toric ICL.
That's true. Fair enough. All right. So I think we've had a good round of discussions. Thank you very much for the inputs, everyone.
Thank you.
Ritu ma'am, would you like to have any remarks?
No, thank you very much. I think we had a very good discussion on a lot of things, and it's an evolving subject. We really need to understand it even deeper. and I'm more conservative. So I've done few intacts, but I've seen the refraction keeps changing. So I've stopped doing them. And a lot of things I don't understand. That's all I just want to say.
So with that, shall we just conclude the session? Shall we wrap
Thank
up the
you.
session?
Yeah, thank you very much.
So at the outset, I would like to thank everybody, especially the viewers of this, I mean, who have joined today, all the participants, the panelists for giving honest and practical tips for all the cases, Neha for doing so much of background work, and our all presenters for bringing in such wonderful cases. And especially, I mean, I would also like to thank the CSI back office people who have just made it very seamless. As far as the meeting is concerned. And thank you, Dr. Namrata, for being here today. We missed you for last 2, meetings.
Thank you.
Thank you very much, all of you. And Shabina, can we have a picture? And I think we finished in a little bit overshooted on time, but that is all right. It was all the points were very well discussed and the cases were very interesting. Shabina, are you there?
Yes, doctor. Taking pictures.
Yeah, could you tell? Yeah. I think some of them are not there. Can we have their, Dipender, and we can have the presenters also here. Nikhil, can you show up?
Even Shabina should show.
But in terms of rings, you should see surgeons from Brazil and South America. They have amazing outcomes with rings, and because they have had so much of experience and they have a wide variety of selection of asymmetric rings, different diameters, different segments, and even different arc lengths as well. And they have been able to really regularize the cornea they keep exchanging the lenses, shifting the lenses, but they do multiple adjustments till they can achieve a pretty good cornea. So I think it's the experience that also matters.
Right.
Right.
All right. Thank you very much.
You. And good night, everyone.
Thank you.
We have our
Thank you.
next.
Thank you, Paras, for being the central figure.
Yeah. And I mean, I was just, coordinating, and we would be having our next meeting on 21st of July with Disha Eye Hospital, and the topic would be HSV keratitis, a clinical masquerade. So look forward to that.
Okay. Thank you.
Thank you.
Good night, everyone.
Good night.